for MNE, and we are privileged to be joined by three presenters from CDC. Our presenters for the day are Nadia, Kat, and Jonathan. Nadia is an epidemiologist at CDC, and she has been working with CDC for the last since 2006. She has specialized in monitoring and evaluation and provide technical assistance in the area of strategic planning, monitoring and reporting, program evaluation, and data use. Now, Kat is an evaluation fellow at USCDC also, within Division of Global HIV and TB. Her area of specialty are evaluation and policy implementation and analysis. And finally, Jonathan is a public health specialist at the US Center for Disease Control within the laboratory system branch in Uganda. His three main areas of specialty are laboratory science, project management, and ICT management, primarily offering technical support to Uganda MOH in both HIV and COVID. We are looking forward to a very fruitful discussion today. Just to remind you that please post your chat question at the chat, and then we'll address them as the session goes, as the discussion progresses. Without further ado, I'll call on Nadia to take it on from there. Thank you. Nadia.
Thank you, Michael. Good morning, good evening, good afternoon to everybody. Kat is actually going to start us off today. Kat.
Thank you, Nadia. Good morning, everyone. Good morning, good afternoon, depending where you are. Bonjour. Thank you for the introduction, Michael. My name is Kat, and I'm here with my colleagues Nadia and Jonathan, and we are excited to join this training and speak to you today about viral load data flow and indicators. So since we only have 1 hour for this session, we're going to save some time and do introductions in the chat. So if you will, please type your name and what country you are tuning in from so we can get a better idea of who's joining us today. And while you do that, I'll go ahead and dive into our session agenda. So today we will review key concepts from the previous session, which include understanding the general components of the M&E framework for countries VL testing, determining the relevant stakeholders involved in M&E, and creating an M&E implementation process, which is a summary of your priorities, measures, and systems. We will then go on to cover topics related to viral load, such as mapping the data flow, reviewing the viral load cascade to inform development or revision of the indicators, what data collection, analysis, and use of VL indicators in a national system could look like. And finally, we will end our session with a presentation from our colleague who will share the Ugandan experience with some of these key concepts. A major thing we'd like you all to keep in mind today is we want to balance the theory and the practice. So this session will provide an overview of theory, but as you listen, please think about how this can realistically translate into practice for your setting. The goal really is to balance the ideal with the feasible and realistic so that you can actually use your plan. Before we kick things off, I'd like to point out that much of our material that we're presenting comes from this World Health Organization technical update document. My colleague Nadia was one of the core authors on this document. It was released in April of 2019 and contains many resources and tools, such as an example logic model, various indicators, forms, and registers that can be adapted for your programs, how to conduct service quality assessments, and much more. For our session today, our main focus will be on section 2, which covers indicators, and we will briefly touch on session 1, which maps data and tools. We included the link to this document in the slide, so please bookmark it or make a note to come back to it after this presentation. And then also note the icon you see here in the top right of this slide, we've used to indicate tools we're referencing from this document. We hope this helps link the concepts presented today to further resources for you to review. So we'll now go ahead and review a few key concepts. As mentioned in February's session, once goals, objectives, and activities have been defined via the program logic model, an M&E strategy should be developed to guide M&E activities. An M&E strategy outlines the key questions stakeholders have about the program, the data needed to answer those questions, and the procedures that need to be put in place to ensure high-quality data are collected in a timely fashion and used for decision-making. A documented plan is essential for keeping track of the specific M&E activities organizations need to carry out and the required resources needed to do this. An M&E strategy outlines what will be monitored and/or evaluated, what data is needed and will be collected to do this, and how the data will be used. It also details how M&E activities will be managed. And an M&E strategy provides a practical framework for implementing your program's M&E activities and can serve as a reference point for other program stakeholders as well. Ideally, an M&E strategy is developed during the design and planning phases of a program. So what's included in an M&E strategy? The M&E strategy describes M&E activities for a program and typically includes the elements we've listed here, 1 through 7. It should also be prepared as an adaptable and living document that will be reviewed periodically. We will go more in depth on these elements later in the presentation and specifically relate them to viral load. So here we provided a template including key sections, which should be included in a national monitoring and evaluation plan for viral load testing. It is recommended that country teams clearly develop 2 parts of a monitoring and evaluation plan, one of which being a performance monitoring plan and the other being an evaluation plan. Strong monitoring and evaluation plans also require clarity on data flow, data elements, and indicators for viral load monitoring. Using viral load data is essential for patient level and program level decision-making and should be emphasized in monitoring and evaluation plans. We'll dive deeper into each of these 2 plans in the following slides, but first let's focus on the importance of stakeholders in the planning process. So stakeholders are key to developing and maintaining strong and functional M&E systems. But why are they key? The information we want to gather through our viral load M&E systems ideally will be used by a stakeholder, someone who has an interest in the program's success. It is important to identify, engage, and involve stakeholders early and throughout the efforts because their buy-in will be critical in ensuring that our systems will be strong and functional. You want to identify your stakeholders and their information needs and determine how you will use them. Using routine viral load M&E data and systems for viral load testing requires coordination, collaboration, and communication between many different teams of laboratory, clinical, and monitoring and evaluation staff. We need all engaged to make sure we have a strong and functional data system at facilities, laboratories, and above site levels to inform data capturing and monitoring and evaluation tools. All stakeholders should be engaged in the assessment, and programs should work closely to ensure that data sources and tools are tailored for viral load monitoring and include relevant fields to record and report viral load testing data and clinical outcomes. We've included a cartoon to really illustrate the importance of stakeholder engagement here. So the idea to avoid syncing, we really want all stakeholders to be included and in the same boat at the same time. So once key stakeholders are identified, it will allow you to move forward into the next phase of planning, your monitoring and evaluation plan. We will provide you with an adaptable template for developing your own monitoring and evaluation plan after today's session. Please note, what we will share and cover today is just an example of how one can lay out the key concepts of an M&E plan and develop a template. There are many different ways to create a template, and it's important to edit it to fit your needs and make it work for your setting. Overall, the plan is meant to be a roadmap to address stakeholders, data flow, indicators, data systems, and evaluation priorities. The monitoring piece and the evaluation piece will speak to one another and have some overlap. However, by separating them, you hone in on more routine measures that you might look at for monitoring, while having a separate eye on specific evaluation questions you might need non-routine data for. So for example, say you want to understand barriers to accessing care. One way to approach this would be utilizing a qualitative method and conducting interviews. This would go in your evaluation template, but it may not go into routine monitoring portion of your plan. And as we've mentioned already, it's very important that you regularly review and update your plan as needed. And so here we have the key components of a monitoring plan, which is the first part of your overall M&E plan. Program monitoring entails collecting and using data related to key programmatic questions, such as how many diagnosed patients were linked into treatment in a certain reporting period. It's important for monitoring questions to be specific, measurable, and relate to program objectives. Once you have your monitoring question, you will be able to then fill out the rest of the table and information needs. These components include, how will you measure? And by that, we mean what indicator will be used. Is there a specific target you'd like to set? Where will your indicated data come from? How often will it be gathered? The responsibility component is optional, which we have listed here, but we feel it's very important to define specifically who will be capturing the data so that there's no issue with something slipping through the cracks. You also want to address other questions, such as data systems and management, so specifying how data will be managed. For example, briefly describe how data will be entered from sites and labs into the laboratory information system and managed in the system for analysis and reporting. You also want to touch on data analysis and quality, So give a brief description of the data analysis and data quality assurance plans for viral load data. For example, you could specify how data will be analyzed at the site, district, and national levels, and by subpopulations. And finally, you want to make sure to cover how to use the data and how you're going to disseminate results, specifying specifically how it will be used. For example, describe how data will be reviewed monthly by districts to assess site performance and how district offices will follow up with sites quarterly to present data and address gaps, underperformance, and other quality issues. Once part 1 is complete, then you're able to focus on your evaluation plan. Listed here are the key components of an evaluation plan narrative that should be included. Please note, these are different than the monitoring questions we just covered. For example, determining an evaluation question. What do you want to know about the program? And from there, you can consider what type of evaluation will address this question. Then you can consider variables we need to answer the questions. Not all indicators will come from our monitoring system. We may need to collect additional information and look at other sources to answer the evaluation questions. Please come back to these slides and the template we will provide to help inform and edit your M&E plan. So finally, at the end of February's session, you were asked to develop or update your VL data flow map, keeping in mind both physical and/or electronic data exchange. We ask that you include all M&E data capture tools used for recording data from collecting samples to returning results, keeping in mind the gaps, challenges, and concerns your program faces. We ask that you prepare this assignment because we wanted you to review your current M&E plan, including VL testing and data flow. You'll get a lot more out of this session if you had time to think about these questions ahead of today's session. We will spend this session going over the concepts, and that will allow you to further refine your assignment, which will in turn refine your VL M&E plans. Keep this in mind as we begin session 4 now. So we'll start today, session 4, with a discussion of mapping the data. Understanding the flow of viral load data is one of the first steps in assessing a viral load monitoring and evaluation system. An effective VL M&E system should have a clear map of how data flow from one source to another and how data are captured at each step. This idea can be used in many different ways, allowing you to outline overall movement of people, samples, and data, identifying data collection tools and systems, and identifying gaps or issues in the flow that we need to address. In general, for VL data, we can have different ways that data move from sites to lab and back to sites. This can be physical only, a combination of physical and electronic only, or perhaps something different in your setting. It's also important to consider how data get aggregated at the subnational and national levels. We won't cover aggregation in depth today, but we will include some considerations as you work on data collection and the planning and improvement of systems. So when we talk about different ways that data can flow, what exactly do we mean? This is a high-level snapshot of the concept. How do the samples and forms with patient information move from sites to where they are tested? And once the results are ready, how do they get back to the sites and patients? The data associated with the samples and results may move physically, for example, by a courier, and/or electronically between different systems. We can also have physical movement of specimens, with electronic exchange of data and results. For example, the sample requisition form may be physically transported with the sample and results may be sent electronically. We can also have integrated electronic patient information systems such that the same information system is used from sample to result return, or perhaps your setting uses something different. These are the models we'll need to keep in mind in this step. And as we discuss the next example, keep in mind your own setting and flow. It's helpful to lay out tools and systems you plan to use to capture the data you need. And just a quick note, in our extra slides from today, we provided an example of data flow with greater detail that you can always return to. So once we have the data flow and steps outlined, we can start to overlay the data collection tools and systems necessary to capture data, and that will inform our indicators. This will help clearly outline where data come from and at what point. Since many participants already have VL testing programs, this exercise should be fairly straightforward. The main point we want to highlight here is that as you're looking at your steps for data flow and collection, be sure to look at them in a holistic way so you have a variety of information sources included, which will result in a broader picture of the program. Here we have an example from Uganda. Since we will hear from our colleague Jonathan about Uganda's latest version of data flow and model update later on in the presentation, We've just briefly included this as an example to review in depth at a later point. The slide here shows the flow from health facility to lab, while our next slide allows you to see the flow from the opposite direction, where data flow from lab back to health facility, or specifically to the patient. Please be sure to review this after our session today. And finally, we also have to consider how data are not only aggregated and flowing from sites, but also to subnational and national levels. This is key to your M&E plans and to how you select your indicators and update data collection tools. The data flow map for this level is generally simpler for viral load than when considering the flow for test and results return. In the visual here, we have noted how data flow from sites to districts to national level. We have also noted the data collection or reporting tools that we will need to use at the various levels to capture the data for key variables of interest. Since many programs will integrate or update existing tools to ensure capture of VL-related data from different variables, this can be a helpful process to outline the pieces. But in order to identify key variables, we will need to be clear on our indicators. I will now hand the microphone over to my colleague Nadia, who will discuss viral load indicators and weave all of this information together.
Hello, everybody. Thank you, Kat. Now that we have discussed the importance of understanding how your data moves and flows between various sites and facilities, we will discuss how to transform that understanding into indicators for viral load monitoring. As a reminder, in February session, indicator development and using SMART objectives was covered. Please review that session for more details about general indicator development. We have also included a couple of additional reference slides on indicators in the extra slides section. Here, we'd like to remind you of a few things to consider when developing or adapting indicators. First of all, think about your program priorities and context, which can really evolve with the program and should be updated over time. Link your indicators to your monitoring questions in your M&E plan and to the desired outcomes you have already outlined in your logic model. Consider any gaps or challenges in your program. Since many of you have robust viral load programs already, you may be aware of existing challenges that you've already identified. Consider these and use them to inform your indicator development and revision process. Consider the cost and difficulty of data collection and analysis. And finally, keep reporting requirements in mind, as these often inform prioritization and selection of indicators, as well as the frequency of reporting. In February session, we mentioned selecting indicators along the HIV response cascade. In the context of viral load, let's see what this would look like. One way to start your viral load indicator development or even updating process is to outline the main steps you think require monitoring. Even if you already have long-standing indicators, this exercise may inform indicator revisions and/or help you identify additional indicators that you may prioritize based on how your implementation is going. We will now illustrate how one may go through this process in the next couple of slides, particularly looking at how you can do this at the micro level or the site level, and how you may think about it more at a macro level or the program level. Outlining key steps for what you are trying to measure is a helpful first step to identify some of the priority areas for developing or adapting an indicator. The table above is an example listing some key steps from requesting a viral load test to monitoring the outcome of a viral load test. We know this is an oversimplification of many steps, but we want to focus on the main steps here. Looking at one of the first steps listed in the table, that is requesting a viral load test, what could we use as an indicator to measure requesting a viral load test? Please type some ideas in the chat. So again, which indicator, oh, can you go back one, please? Yeah. What is an indicator that you might use for requesting a viral load test? Just type some ideas in the chat, please. Nobody? Any ideas for how we might measure requesting a viral load test? Right, exactly, that's great. Number of viral load tests requested, yes. And what if we wanted to measure the return of viral load test results? What's an indicator we might use to measure that? Sure, turnaround time. Any other ideas? Perfect, number of results returned at the facility. Great. This is just a small, number of results received, absolutely. And what's interesting about all of the answers that people put in here is they're slightly from a different lens. Okay, another interesting one, Michael. Yes. So this is just a small exercise to illustrate how we can use a process like this to identify indicators that we can use to measure success. You will have an opportunity to better refine indicators from this type of exercise as you think about systems, tools, and resources. It's another interesting one, number of samples rejected. So here is our table that we started brainstorming on, but here we've included the indicators that one could think about or possibly use. Just because we included a step and an indicator in our table above doesn't mean that we will finalize an indicator for every step and reflect it in our M&E plan. It also doesn't mean that we must routinely monitor the indicator, even if we decide to include it in our M&E plan. This exercise can help to identify which steps we think are very important for measuring, what indicators we develop or adapt to measure a step, how frequently we would like to monitor the step or outcome. This will also inform our data collection discussions, especially because we have already mapped the data flow and tools. This will also help us to prioritize indicators that we want to measure. We can still include indicators in our M&E plan that we think are important, but may be burdensome to routinely collect from all sites through national systems. We can identify these indicators through our exercise, but note a lesser frequency or reporting, and also note a different data source in our M&E plan. One example of an indicator like this may be the percent of patient charts with documented viral load tests and results in the last 12 months. This indicator may be easier for programs with patient-level electronic systems, but may be more burdensome for paper-based systems. In this case, we may decide to collect the data during more intensive site visits or assessments. We can note this as well in our M&E plan. There is a more complete table similar to this one in the WHO document that we referenced earlier. We included a snapshot of this table in the extra slides section. You can review and adapt it for your setting. Now that we spent time on thinking about the steps at a micro level, we can move to looking at a macro or program level that really aims to understand how our program is tracking overall viral load coverage and outcomes for patients. The cascade on the slide tracks patients from PLHIV on ART to viral load testing access, to receiving a test, to those who are virally suppressed, and finally, to those who have been referred to a less intense model of care since they are stable. We have also included the indicators that can be used to track each of the steps. You can see how this type of a product may result from the earlier exercise. While this is a pretty standard high-level cascade and several programs may be tracking similar indicators already, there may be additional indicators to consider for your M&E plan. Some of these additional indicators may have been identified through our previous exercise. For example, perhaps your program is struggling with results return, and you decided to prioritize an indicator on the proportion of results received at sites. That indicator could fit in between received a viral load test and virally suppressed in our high-level cascade shown on this slide. This is how we can start bringing the pieces together to ensure that we have an M&E plan that reflects our specific program priorities, gaps, and challenges. As you are updating or developing your M&E plan, be sure to focus on both the micro and macro level to find the right balance for your setting, especially if you have identified gaps or challenges in your programs that would benefit from specific monitoring indicators. Our previous cascade focused on clients who received a virally suppressed result. What about those who have a result of not virally suppressed? This cascade highlights the indicators that we may want to consider for those clients. A quick note that not suppressed in this cascade is defined as greater than or equal to 1,000 copies per ml, but your programs may define it differently. Our cascade is aligned with current global and PEPFAR indicator definitions. For time's sake, we won't review the entire cascade. The main utility of reviewing a separate cascade for unsuppressed clients is to help identify unique indicators and data collection tools to track steps along this cascade. One example of a data collection tool specific to this cascade would be a high viral load register. We have observed that while programs may want to measure this entire cascade and therefore have robust indicators for this entire cascade, it can be challenging to track individual patients, especially in paper-based systems. So the indicators finalized in your M&E plan to measure the steps along the cascade may vary depending on feasibility, resources, and relevance. Finally, a note that the indicators in your programs may also be further adapted based on your subpopulations. For example, there may be differences with an indicator to track enhanced adherence counseling when tracking non-suppressed pediatric patients compared to non-suppressed adults. That is all determined by your program priorities and context. Going through this process may help to identify and address some of these differences between your various populations. Another important factor in finalizing viral load indicators are disaggregations. Disaggregations for indicators are extremely important for providing more granular information of subpopulations and for other factors or variables. Disaggregations for age, sex, priority populations such as pregnant women, breastfeeding women, and key populations are generally included. TB status may also be considered if tracking outcomes among those with active or non-active TB. You may include additional disaggregations for your context and settings, but keep feasibility, resources, and frequency of data collection and reporting in mind. This is a resource that may help with work on viral load related indicators. Annex 5 in the WHO document that we've referenced provides several indicators that can be adapted for your program, and they're specific to viral load. Note that the layout of the table aligns with parts of the M&E plan template that we presented earlier. Also note that the indicators in this table are meant for adaptation by different programs given your setting. We hope that you find this resource helpful. Even if you have a core list of indicators that you are already using in your programs, it may be helpful to review the annex to identify additional indicators to address identified gaps for more frequent monitoring. Finally, once you've identified the key indicators that you need to measure, it will be time to reflect them in your M&E plan. You saw this template at the beginning of our presentation, and I want to revisit and highlight the importance of completing the components specific to your indicators, particularly specifying the data sources, frequency of collection and reporting, and who is responsible for capturing the data. The level of detail you include will vary. For example, for frequency, you may just say quarterly or monthly. For data sources, it may be useful to know the exact form, register, or system that the data are going to go into and that you will use to capture the data. M&E plans and indicators are dynamic and require updating and review as your program evolves. We will now shift to covering data collection, analysis, and use. The ability of programs to examine monitoring question depends on both availability and quality of viral load data. Remember, data from multiple indicators may be required to answer one question. Effective tracking of viral load testing and patient outcomes requires multiple M&E tools and systems from multiple locations, such as facilities, labs, and specimen transport networks. We started to visualize and outline this during our data flow mapping section when we overlaid our tools with our data flow. Standardized data collection and reporting tools are needed so that we can collect site and individual level data to aggregate it across the program as we monitor our program performance. National tools are essential to standardize across the country to do this. As you know, there are many tools such as forms, registers, electronic systems that we use for collecting data. We may integrate viral load related variables into existing data collection tools or systems. Country programs may have existing tools that simply require some updating to effectively track viral load. We may also need to develop a new tool specific to viral load M&E. It is essential that programs understand how all the M&E data collection tools and systems are used to collect and report viral load data. In just a few minutes, we will hear more about Uganda's experience with revising its data collection tools and systems as their program has evolved. Also, please note that in the WHO document, Annex 3 includes examples of national and program data collection tools. These may be a bit dated, so I would encourage participants to share additional, more recent tools from your programs with one another. A couple of quick reminders on data collection. As we know, there are two categories of data, routine and non-routine sources. Routine data are collected on a continuous basis. This is usually our data that we report and monitor regularly. Non-routine data is collected on a periodic basis. In the context of viral load, this may be some of the data we collect during intensive site assessments. These data may be burdensome to collect frequently, but they are important to assess quality of our program. Another reminder, refer back to your M&E plan that you developed. The questions that you included will also guide both your data collection and analysis. And finally, think about your data quality up front. It's important to guarantee data quality prior to data collection. Development of data quality protocols, standard guidelines, and procedures are key to ensure the accuracy, completeness, and timeliness of data. These SOPs can also help to ensure consistency in indicator definitions and to define the responsibilities for data quality at each level of the system. These should be considered when training staff who will be recording and inputting data into systems. We're not going to spend too much on this slide, but it's just a reminder that as you're developing your indicators, data collection plan, and tools, be sure to consider all of the dimensions of data quality listed above. It is also important to regularly conduct data quality assessments and use findings to improve data. This should be considered and included in your M&E plan. And as a reminder, it's really important to think about your data quality before you even start collecting your data. There will be an upcoming session dedicated exclusively to data quality, so stay tuned for that. Data analysis and use should include analyzing overall viral load testing coverage and outcomes at the site and above site levels, and analyzing data along the viral load cascades. Viral load outcome indicators should also be analyzed by various subpopulations as captured by your indicator disaggregations, a few of which are listed here. Analysis based on geography, site type, and other contextual factors will also be important. Data analysis may also be cohort-based or cross-sectional, depending on the analysis question, your resources, and the available data. Country programs have increasingly been using dashboards for routine analysis. Real-time availability and review of data for key metrics displayed with graphics and visuals have been essential in promoting the use and understanding of data. Finally, as I mentioned earlier, use your M&E plan to remind yourself of the key monitoring questions you wanted to answer about your viral load programs. That is also very helpful to guide our analysis. We'll now quickly share a few slides to show various examples of data visualization. For time's sake, we won't go through them in detail, but we wanted to include some visuals and links to dashboards that could be used or could be referenced and informed your efforts. We will also include some links, as I mentioned, for the various dashboards. So this is a very simple visual showing the two different cascades we went through with the actual data. The one on the left is showing our viral load suppressed cascade. The one on the right shows the cascade for those who are not virally suppressed and follows them to the outcome, the final outcome. Here is a cascade focused on those who were not virally suppressed. It is showing more disaggregation for the cascade than the previous cascade we saw for non-suppressed individuals. The point being that you can vary the level of detail that you're showing in your different visuals. Here is a snapshot of Uganda's viral load dashboard. There are several key metrics to select from, such as samples received, suppression rate, rejection rate of samples, etc. In addition, the dashboard includes disaggregations for users to see data by subpopulations or other characteristics. And finally, this is a snapshot from Kenya's viral load dashboard showing outcomes by age and by reason for the test. Finally, this last slide has a few links for other dashboard examples that you may want to explore and take a look at. If country teams or participants have other examples that they would like to share with participants, please do share that with the rest of us so everybody can learn from one another. Finally, we'd like to tie this all together. At the end of February session, the presenter asked what challenges listed on the slide above you are facing for viral load M&E, with the most popular answer being all. And that means that everybody felt that challenges included no defined list of indicators, no logic model, poor knowledge of M&E, and no M&E framework. In addition to the information presented in this session, we've linked here specific resources to address some of these challenges that you're facing. Please revisit this slide after the presentation today to access the information. I'd like to now hand over the microphone to our colleague, Jonathan, who will tell us how Uganda has worked to update data flow, tools, and systems for viral load as their program has evolved. Thank you.
Thanks, Nadia, and thanks, Kat. And surely you've already let me get my juices up on the session about data quality. I'm really excited about it. And just like both you and Kat highlighted, the stakeholder mapping and the key questions are very, very important for us to answer right from the beginning. And noticing that for many of us, our programs might be in their advanced stages. Just as many people have mentioned that their viral load needs might be, the M&E needs might be everything. So I will try and give a picture of that. But we've appreciated a lot of support from the CDC HQ and also from ASLM. Let's go on. So I'll just give a small picture on the current VL coverage and suppression in Uganda. The process of identifying the gaps for VL data monitoring, and then updating an update on the national tools to address the gaps. Let's go on. So this is up to FY20 Q4, that is September last year. we had reached a viral load coverage of 88%, and the suppression was at 92% for all the people tested. Let's go on. Our process of identifying the gaps in the VL data and monitoring was similar to peeling an onion. And just like Nadia and Kat really emphasized, the step of identifying the key questions is so important. And it's like peeling an onion. You start off with the parts which don't make you cry, but the deeper you go into the onion, the more you will find tears coming out. So when you look at the geographic coverage, the review of the total outputs versus your targets, you just set those general targets at the beginning and then the annual site level targets. Those are the broad things which you look at from the outside. But when you come into the parts which are really painful, for example, if in Uganda, one of our big questions that our program team wants to know is the regimens for the different persons, both for people suppressing and non-suppressing. That is very painful data to get. Then information such as the age bands. The more granular the age bands discussion becomes, the harder it is to collect the data. And you'll find that it really challenges us going on. Let's go on to the next slide. So as mentioned earlier, we had to give ourselves a lot of time, both as the lab systems people and the program people in care and treatment, to ask and answer our key questions. And so when we were developing this lab request form in 2014, we had to make sure we sit together. It was quite painful because we had a lot of indicators. But we've been revising this form almost every 2 years. We actually did a review of this form, which was complete about 2 months ago. And the main part where we changed was the ART regimens, because people have been moving from different types of regimens, NNRTs to PIs and things of the sort. Then the reasons for testing, those ones have generally remained the same. And then the treatment information has changed a little bit. For example, we still ask about the duration on ART, the pregnancy status, the TB co-infection, and the line of ART regimen. Those ones have been standard, but there are other questions that we continued to shed off as the program was going. So we've had, I think this is like up to version, this is probably version 5 going to, which was released a month ago. And so this picture might look old, but it is one which changes every other period when you meet with the different teams to change this. And it's a key thing that all countries must sit down to revise both lab and the clinic teams. Let's go on. Next slide. So in terms of the lab data flow, it doesn't differ much from what Kat had shared earlier on. The visuals are quite the same. We've tried as much as possible to become more and more electronic, but it's generally the same lab flow. So from the sample collection, which is done on paper forms, referral is done using the paper forms. The VLEID results are electronized, and from that step onwards, everything becomes electronic. We have tried to automate the sample referral process, putting sample tracking apps at the site level, at the hub level, and the adoption has been varied across the different implementing partners in Uganda. But at least one thing we have been able to do full electronization is at the part of testing and results return. So the picture on your right just indicates the same thing about the referral of the VL and EID testing, with the dotted arrows showing the automated data exchange, and then the part where we are really trying to do more electronic data entries. If we can achieve full electronization of the system, most of the M&E needs will be met in situ. Thank you. Go on. So in conclusion, when we are trying to implement the M&E systems, the systems need to start from the source. When your data at source at sample collection is not good or not sufficient, it will not be able to meet your needs at the end of the day. Then the future of effective VL M&E is point of care EMR integration with the respective information systems. We've kept on asking different partners, and a couple of days ago we were having a meeting, regional meeting with various countries on EMR, and very few countries have been able to link their ART data 100% with the VL data. So we still have, to a great level, an assumption that the number of samples tested is equal to the number of people who are tested. So the stepwise approaches that Kat and Nadia went through very, very well are so important for us to be able to identify what the current needs. With the SLM support, there have been capability matrices which we've been reviewing as country teams annually to review what our country needs are, to see where you are. So it's very good that maybe once a year, between the lab and the treatment team, we review these capability matrices, and then we are able to tell ourselves what we should focus our energies on. Then finally, there is still increased demand in tracking, and this is now from the care and treatment. There's an increased demand in tracking VL against things such as the ART regimens, HIV-DR, and then pregnancy and breastfeeding status. So these are the disaggregates. That's the deeper part of the onion, which the systems go to. As you're going closer to the 95, 95, 95, those are the key things that you need to look at in greater depth. Next slide, please. I think this is it. So that's the brief we can give, thanking all of you for the work you've done. We really deeply appreciate the support from the headquarters. Nadia, we thank you for staying up for our pains. Kind regards.
Anything for the Uganda team, Jonathan, anything.
All right. Thank you so very much, Nadia, Kat, and Jonathan, for that extremely, extremely informative presentation. We have about 12 or so minutes. I'm seeing a number of questions. There are not many, but there are a few questions that have come in within our chat. I'll just post them as they have been asked. The first question comes from Faith, and she's asking that within the Cascade, would you advise to include number of people who are eligible for VL out of the total number of people on treatment?
Yes, that's a very, very good question. And yes, I think that should be included. I think if we go, let me just pull up the Cascade really fast. Yes, I think for the VL one, I mean, the assumption is that for coverage, you would, I mean, that's sort of getting at the coverage, right? That, I mean, depending on the guidelines that one would have, you would expect all to be eligible like within a 12-month period, right? But you're right, because when that eligibility comes up and how you're looking at coverage will vary depending on when you take your snapshot. So yes, I think so, yes.
So thank you. Now, I'm going to combine a question from Collins and a question that I asked because I think they are related. So Collins is asking that what effort would be needed to capture data or number of patients with non-suppressed viral load who receive EAC and enhanced counseling at national level. Now, we want to link that up. Every country that's participating within LabCoP, they do an assessment of a self-assessment of their own Cascade, and we have seen that data availability, especially at national level, for VO Cascade for patients with non-suppressed VO test remain a major gap. What would be your guidance on how best to handle this challenge?
That's such an excellent question. And Jonathan, I'm gonna kick it to you after I provide a little bit of my thoughts, but I think that your input will be much more helpful from the field. But I think that particularly with the enhanced adherence counseling question, we've definitely seen that also has been a challenge. And even like you were saying, getting data for the entire non-suppressed cascade. And I feel like when we had these conversations years ago as viral load testing programs were being scaled, one of the challenges was that there's already so much that you have to put in the system to get the suppressed data, right? Of those patients who are suppressed, that people were sort of running out of steam for the non-suppressed. So, but at the same time, they're the patients we need to be the most worried about, right? Because they're the ones that, you know, are not necessarily, something's going wrong with their treatment, or that we have to support them in some way. So I think what we've seen is a combination of sort of compromises, if you will. Some data that is being collected to the national level, some of those pieces of those indicators that we showed from the Cascade being collected and being prioritized for tracking at a national level, and other parts of those indicators that people focus on during, for example, site level assessments. So for example, I've seen for some of the EAC indicators, people doing that when they go on site visits and sort of dedicating specific time to go to certain sites that they know might be struggling, or that, you know, they randomly select sites and do more of an in-depth dive. Jonathan, how would you share anything about some lessons learned from Uganda, or how you guys have approached it?
Yeah, sure. Your question is excellent, and what Nadia has mentioned is spot on, in that it's such a pain to get this first set of data on people who are suppressed. Now getting the non-suppressed is the bigger challenge. Fortunately for Uganda, we have benefited from the LabCoP project, which you might be familiar with. ASLM has done a scale-up support in many other countries. But when we participated in the LabCoP, we got greater insights on developing a register for non-suppressed people. So we are able to get that cascade. I was not able to present the register because I wanted to get a live picture. I wanted to present a live picture of it, but it was not present because our HMIS tools for it are not yet, they've not yet been deployed. But at least we've reached a point of success whereby we are at the level of deploying a register for all the facilities to track their non-suppressed clients in a similar cascade to what Nadia shared in the graphs. But prior to that, the LabCoP project was really a good starting point. When you introduce that CQI to a big number of facilities, because we made it as a national CQI initiative and picked over 500 out of 1,700 facilities to try and implement LabCoP together with our program team. The facilities started adopting this and developing their site level registers, but we are at the level of developing, of rolling out a register, which is in the MOH standard. What different facilities and different partners were able to implement had some variations, but now we're going to be able to standardize it, and it will not be something new because this is a CQI activity which has happened from 2019 and, well, part of 2020 because of COVID, yeah. We've not gone diligently to the field, but at least it's something we've learned from. Thank you.
Thank you, Jonathan.
And thank you, Jonathan and Nandia. There's a question that's coming from Dret. Dret is from South Sudan, and he's asking, looking at the viral load suppression indicator on the number of clients with documented VL test result in the file in the last 12 months. And he's saying collecting data for this indicator require getting back to update report and some result in one month are received in the facility. Basically, he's expressing what the challenge that basically goes with collecting data for this indicator. And he's asking what can best be done. And he would want to hear a little bit more on how others are dealing with this. Thank you.
Right. So I'll start, and Jonathan, you also please chime in, because I think the experience that Uganda is having from really seeing their system evolve from primarily paper-based at the facilities to more electronic is the key piece of this. So as I mentioned when I was presenting, for that type of an indicator, depending on the systems you have in country, you may prioritize that kind of an indicator for site visits. And I know that for some of the harder but very important indicators, I keep bringing up site visits, but it's really to say that some of the stuff that we think is very important, it's not feasible given our systems to collect them on a large scale. And until we get to having more EMR type systems where we can have queries and we can draw that data out from those systems, we will have to rely on ensuring that we have very kind of clear and, you know, quote unquote clean data assessment or site assessment type forms in which we can actually keep checking this when we go. So I think it really depends on your system is my point. I think if it's paper-based, it ends up having to it's not something that can necessarily be reported up as frequently. If it is electronic-based, depending on your system, depending on your electronic system, you might actually be able to have a query. And so Jonathan, just from your perspective and given all the amazing work that we've seen in Uganda, please add or edit what I said.
Yeah, thank you, Nadia. The more electronic you're able to go, the easier it will be to account for that, because the indicator is clear that it wants the data, evidence that it has reached the patient file, or at least it has been used. So for our case, what we did was to increase the number of sites that are able to download their results individually. And second to that, we are trying to work out a system, and we have had some good stuff going on in Kenya, but we are trying to see if we can direct all the VL results through health information exchanges straight into the EMRs at those respective facilities. Right now, our EMR coverage in Uganda is about, it's 1,200 out of 1,600 something facilities. So with such a good EMR coverage, and yet it's still increasing, if we are able to hit it right and be able to refer all those results electronically straight into the patient registers, as soon as a patient is going to visit a site, they will give the person the result, and we will have sufficient confidence that the facility has all their results. It will resolve that issue of getting the results on the patient file. We're also trying out another approach in which we want a client-led results return system, whereby the client can send out an SMS and be able to put in some codes to confirm that this is the right client, and then be able to receive their results. Something of the sort, such that we know that the client has received their results. So we will be able to give a proxy that the patient file has been reached. That way we'll be able to meet the requirement for that monitoring element. Thank you.
And I think I just would like add on to that Jonathan's example is just such a wonderful example of sometimes at a global level, we might try to brainstorm for an indicator. And I mean, we might make a recommendation for an indicator, but you can always adapt it in country given your situation. So I think that's a wonderful example of how you could do that.
Thank you. We have 1 more minute, and probably there are 2 questions. One comes from Caridia, and the question is whether you have any example of a country that has enhanced adherence data. And to Jonathan, a question from Kirui is asking, how is Uganda handling unique ID for clients when calculating or doing summaries? Thank you.
Should I take the first one, Jonathan, and then you close us out with the second?
Sure.
Okay, perfect. So for the first one, that was I put an answer in the chat, but maybe that wasn't seen. But the EAC data, we actually included an example in the slide deck, but we went through it really fast, which was in the data visualization section, and it was data from Eswatini. But it wasn't something, as far as I know, that they're collecting nationally. It was done during a site visit. So they went to a site and they looked at that information, and then they were able to show the whole cascade with more disaggregations in it. So I would recommend that once you guys get the slide deck, just take a look at that to get an idea of how they were showing it. Jonathan, over to you.
So for the unique client identification, it's something which is in the works. We actually do have a community of practice with our HIS team trying to resolve that. But basically, over the last 3 years, we have tried to scale up the use of biometrics at all the point of care EMR sites. We are trying to do biometrics for our ART clients. We are also working on a national client registry so that at least at a facility level, we will be able to deal with the issue of uniquely identifying a client, because the unique identification, the challenges start from within the client itself, within the facility itself, even before we go outside. So we are trying to work on a national client registry for that. We're also, but at the moment we're using the biometrics and the national ID. And our initiative to do health information exchange is really helping us to fast track some of these things, especially as we are starting off with the high volume sites. They do give us lessons to learn for the lower sites, which are those which are in bigger numbers. Over.
So thank you, Jonathan, and thank you, team. We are 1 minute past the hour, and I would want us to come to the end of the session. But as we do, I would want to invite the 3 presenters to make any closing remarks, and probably when at it, you can mention something that maybe the countries need to do to improve on VL resort utilization. Please go ahead.
I think for me, I would just say that I would just emphasize something that Jonathan said and something that we tried to also cover in the earlier sessions, which is I feel like a lot of times we just jump straight into indicators and we just are like, what do we need to report on and what do we think is important? And then, you know, somebody else looks at our data and says, oh, you're having an issue here. And then we kind of scramble to make an indicator to address it. And while I completely understand that's how it works in reality, I would just strongly recommend, you know, if possible, if we're at a point where, especially when our programs are doing like, okay, like take a step back and say, what exactly, how can we lay this out in a way that's a roadmap for us? That's why those questions are really important, those analysis questions, because then we're not just in reaction mode all the time and we can be much more deliberate about what we're monitoring. And I think I would also say somebody asked a question about no implementation downstream. And I thought that was such an excellent question. And I think this is the piece where your stakeholders really become important, and stakeholders at every level, you know, like from your clients to your site staff and up. Because if people see if they see the added value in doing these things, they're more likely to do it. And then our system is likely to be stronger. So I think I'll just say that. The last thing I just want to note is that I saw some questions about turnaround time, and for time's sake, Jonathan had included a slide to talk a little bit about that, a graphic. So you'll see that in your slide deck, I believe. But hopefully that would help a little bit. But I just wanted to say you know, he did think about it, but we didn't have time to get to it. So I'll just leave it there. Go ahead, Jonathan.
Thanks, Nadia. Thanks, Kat and Maina. My remarks would be that for a country to have an effective M&E plan, there are lots of resources, like Kat and Nadia showed, the WHO toolkit, ASLM has a wealth of them. But country teams need a lot of support to be more objective in identifying their needs. The pictorial of the onion was to show that we need to go from the not so painful things to the level of the painful things, because the different stakeholder needs sometimes are so deep for one group to think about them. So if lab alone wants to develop the M&E indicators, they will not be meaningful for program. The program makes their own M&E indicators. The lab people might feel like it's just at the surface of it. So the support from entities such as our CDC headquarter team, from ASLM is very, very much appreciated in that it helps to bring a voice of autonomy. I can tell you that for 2018 and 2019, we had a lot of support from ASLM, the meetings we had in Addis and other countries. It is the time that we were able to sit back and say, look, from 2014 to date, what have we been doing? And we were able to polish. Whenever we're working on indicators, we do come and ask Nadia what is happening on a global perspective. And we brainstorm on what's working and what is not working. Like, for example, the disaggregates for pregnant and breastfeeding and how to report on them, their viral coverage and suppression across countries. Those are sticky issues that, that sometimes need an external eye to give you the perspectives from different countries. That's why we are really hungry to hear about the data quality. That next presentation, our eyes will definitely be looking out for it. It's a very good pick, and it is very timely at a time in a season such as this. Thank you.
Thank you. And finally, Kat.
Yeah, I know we're at time, so I'll just quickly say thank you all again for tuning in. The only thing I'll add, I think Jonathan and Nadia covered a lot of really great things. Opportunities like these sessions where you bring in a lot of different country teams to learn from one another are paramount. So I think continuing to tune into these, talking to one another, finding out what's working and not working, and trying to learn from each other is something to incorporate and really encourage learning and growing in. So thank you all.
Thank you so much. Thank you, Kat. Thank you, Jonathan, and thank you, Nadia, for the very good presentation. We apologize, we went above by around 6 or so minutes. So I'll be sharing the presentation and the additional materials. And thank you so much. Good morning, good afternoon, and good evening, everyone.